you the same advices. So without you, let us start.
So yes, please, we can start.
The cases are simple and most are frequently coming cases and nothing else.
Hi, Dr. Faiza, can you hear us?
Yes, Dr. Asad, I'm here.
Okay, you are on the hot seat now.
Thank you.
See now, share. You can see my case?
Yes.
Okay, you can start.
So I have been provided with the chest X-ray frontal projection of a skeletally mature patient. The most striking abnormality that I can see is bilateral pneumothorax, and there is also the fluid level in the right side. So it's hydropneumothorax on the right side, and cardiomediastinal shadows appears to be normal. I can see bilateral hyla appears to be bulky, but as there is a pneumothorax, so there is a crowding of the vessels and lung parenchyma, and bones and rest of the soft tissues appears to be unremarkable. I would like to, there is no, I would like to ask history of the patient. If the patient is presented with the trauma, then it could be due to the traumatic.
No history of trauma.
So it might be due to the bilateral pneumothorax and hydropneumothorax on the right side. It could be due to the underlying lung pathology, but I'm not been able to see any gross lung pathology, or it could be due to the spontaneous pneumothorax, but it will be less likely bilateral. So I would inform
Why
the
would
referring.
be less likely spontaneous?
Sorry, it could be spontaneous, and in the thin lean patient, it could be due to the previous history of asthma, and it could be due to that. I will inform the referring physician about my findings and inform about the urgent management of the patient. I have been provided with the X-ray left shoulder and arm frontal projection of a skeletally immature patient. I can see there is a fairly well-defined lucent lesion in the proximal metadiaphysis of the left humerus, and it shows the narrow zone of transition. I can see there is a cortical break within along the medial and lateral margin of the bone, and I can also see a bony chip within the lucency, which is likely due to represent the fallen fragment sign, and I cannot see any calcification or any significant periosteal reaction in this, and soft tissue, overlying soft tissue appears to be as there is a bandage, I think, so it appears to be swelling. Rest of the visualized bones appears to be unremarkable, and so in this age group, my first differential would be the simple bone cyst, and as there is a fallen fragment sign, so I will and as the differentials could include aneurysmal bone cyst, but it's is it less likely because I cannot see any septations within it. And I will in my routine practice, I will also see the other view if available, and yeah, on the lateral view, I can see I can see my findings, and I also can see the fallen fragment signs. So my diagnosis will be the same. I will inform the referring physician and advise the management of the fracture, and convey my findings to the referring physician.
How do you think they treat?
Sorry?
How they treat?
They will, as there is a fracture, they will, I think, curettage, and they will, because it is presenting with the pathology now, so they will treat it. Otherwise, if it's not, they can follow. So they will do the curettage, I think.
Okay.
I'm not
Okay. Okay. Next case is an 18 years female who presented with primary amenorrhea, and we do an MRI. Which sequence would you like to start with?
I will, if available, I will try start with the T2 sagittal, or
yes.
Sorry, I forgot the age of the patient.
18.
18. Yeah. So I have been provided with the MRI pelvis of 18-year-old female who is presented with the primary amenorrhea. Can I ask for control?
You can ask.
Thank you.
Approve, please.
So I can see the adnexa bilateral, or visualize. I can see the bilateral adnexa, and however, I am unable to appreciate any uterus, and there is. I can see the distal, like half of the vagina, but upper half of the vagina, and I am unable to visualize the body of the uterus. And I'm looking for the other conditions which are associated with this condition, and I would like to see the other images if available. Can I see the other as well? Sequences. So I'm looking at the T2 axial images, and I'm unable to see the uterus. I can see the left and right adnexa, and however, on T2 coronal images, visualize bones and muscles unremarkable. So I would, in my routine practice, I would like to have a view of the abdomen of the patient, because as in this age group, patient is presented with the primary amenorrhea. My first differential would be Mullerian duct agenesis, and it's Mayer-Kosser syndrome. I'm forgetting the name. And it is associated with the other renal anomalies. So I would like to have a ultrasound of the abdomen, or if I will be provided with the MR images of the upper abdomen, and I will refer the patient to the gynecological MDT for the further management and management of
what
the
other Mullerian duct anomaly you know?
Sorry?
What others Mullerian duct anomalies you know?
These are during the developmental fetal development. The genitourinary system developed from the Mullerian duct, so it could be isolated, or they could be associated with the other anomalies like renal agenesis. It could be ectopic.
Okay. I mean, what other classification or other types? Do you know other types of Mullerian duct anomaly? You are right in your diagnosis in this case, but I am asking only other Mullerian ducts anomalies.
Sorry, I'm not able to recall. Right.
Classification or other types.
Sorry, I'm not able to
Okay.
recall right now. Sorry.
Change. Where's the movement? Yes. Next.
I'm a 45-year-old female with chronic abdominal pain and fatigue.
Okay. I think still you have the control.
Okay. I have been provided with the contrast enhanced CT, abdomen, pelvis. First, I will have a look overview of the whole scan, and so I can see there is ill-defined speculated soft tissue density mass is noted in the right side of the mesentery, in the right lumbar region, and I can appreciate a few specks of calcification within it. There is adjacent fat stranding, and I can also see the convergence of the adjacent bowel loops towards the lesion, and however, and there is also however, I cannot appreciate any obstruction of the gut loops, and rest of the abdomen liver appears to be unremarkable. I am not able to on this portovenous phase, I think, but I would like to see the liver on the arterial phase, and there is also lymphadenopathy, sub-centimeter lymph nodes in the para-aortic region, and so my differential rest of in the abdomen, I cannot see any gross pathology. So my diagnosis will be the irregular speculated lesion in the mesentery with calcifications, and I would like to see the coronal as well, and it is associated with the desmoplastic reaction, and I can also see the bowel loops turning around it. So however, I am unable to appreciate any lesions within the liver, so it is carcinoid. My first differential would be I would like to inform the referring physician and advise the octreotide scan for the further evaluation of the other lesions, and I will also refer the patient to the gastrointestinal MDT, and I will advise the staging CT chest and thorax and abdomen, and further management and further discussion in the GI gastroenterology MDT. I've been provided with a 35-year-old female, pain right hypochondrium radiating to the back off and on for the 1 year, no history of fever or bowel or urinary symptoms. I've been provided with the ultrasound images of abdomen. So I'm looking at the right now at the right kidney and liver. I can see
you can change and make different images.
Okay, thank you.
Yeah.
So there is fairly well defined hypoechoic lesion at the level of porta hepatis, and between
It's
the liver
actually
and
in the
kidney,
liver,
Morrison's
yes.
pouch. And sorry?
Yes, yes, as you mentioned, Morrison pouch, or let us assume within the liver, the kidneys is okay.
Okay. So I can see the debris in it, echogenic foci and layering of the debris in it. On the transfer images and on the Doppler, I cannot appreciate any flow or vascularity within the lesion. There is a minimal vascularity around the lesion, and rest of the visualized structures appears to be unremarkable, but in my routine practice, I would like to see the whole of the abdomen and the
Yes,
anechoic.
the whole abdomen,
has
other no cyst in the kidneys, no, nothing, only here.
Okay. I can appreciate an echogenic area at the upper pole of the right kidney, and it
Just ignore it. Maybe.
okay.
What's your differential here?
Anechoic cystic lesion in the Morrison pouch with debris and non-enhancing. It could.
I tell you, in Morrison pouch, and it is in liver parenchyma. Just
Okay.
believe me. There
Okay.
is
So liver.
parenchyma. Yes.
So it could be the exophatic lesion rising from the liver, and it could be as the patient is not presenting with any fever, and it could be but as there is a debris, it could be the simple hepatic cyst, and it could be hydrated because I can see the debris inside it. However, I'm unable to find any like membranes or daughter cysts in it.
What
But
else? Serology for hydatid was negative.
sorry.
Serology for hydatid was negative. What else?
So it could be like colidocal cyst, but I would like to see the biliary channels and to exclude my finding, and it could be.
Okay. What else?
I would like to advise the contrast enhanced CT abdomen pelvis to further evaluate the lesion, and I will inform the referring physician about my findings. So I have been provided with this is the same patient?
Let us assume same patient.
Okay, so I've been provided with the contrast enhanced CT abdomen pelvis, which I can see a well-defined cystic lesion, which is exophatically located within the left lobe of the liver and extending down, and I can see multiple septi in it, and there is also some other lesion which is adjacent to it, that might be the adjacent to this, and I can see that in no calcification, no
So again, what is the differential diagnosis? What else?
Sorry, time is up.
So it is hydrated cyst, and my first differential would be the hydrated cyst, and other differentials could include the abscess if the patient presents with the fever and raised inflammatory markers.
Okay, time is up. Okay, great, well done. This what actually I have also to me. They might present in give you instead of, let us start with this case, instead of CT, they might give you MRI with contrast abdomen. So the differential, as you mentioned, simple cyst.
I'm sorry to interrupt, Dr. Awadh. Dr. Asad?
Can you
just
hear me?
one tone. Yes, just 1 minute, Dr. Awadh. Dr. Asad, can you just stop recording for a minute? Just for a minute.
or polycystic. Caroli also could be involved. And even if you mentioned, I mean, biliary cystadenoma also is there, other different. It is a case of differential diagnosis, but biliary cystadenoma also to be mentioned. Other case, let us. This one, perfect, nothing to be add. You mentioned everything. You must also add, I think you mentioned there is no associated the complication, no bowel obstruction, no bowel ischemia.
Yes.
Otherwise, perfectly done. Carcinoid. And this, what I mean by other Mullerian duct anomaly, the only question I ask you, that it is just as simple as uterine didelphys, bicornuate, uricornuate.
Yeah.
That's what I mean, yes.
Yeah. I forgot.
This exactly as you mentioned, the because of pathologic fracture, it is emergency. They must refer urgently to the orthopedician for fixation, and they do grafting and curettage, as you mentioned. Yes, this you get it well. No rib fracture. I said no trauma, so it is spontaneous. Other causes as rupture, bleb, or and you do well in all cases. So perfect.
Thank you so much. Thank you, Dr. Awadh.
Okay. Next, who's next?
So I will be going next, Dr. Awadh. Just to ask you, do we need to keep time?
Yes.
Okay,
Time,
so I will ask Ruby to keep the time, please.
Sure.
Thank you.
this is your first case.
Okay,
Yes.
so I am presenting with the bone scan images of a patient. I'm just going through the images for a while. Okay, the striking abnormality, I can see there is evidence of there is no uptake within the kidneys, I can see, and this is suggestive of super scan, I believe. And there is diffuse uptake within the skeleton, and no differential uptake within the soft tissues is noted. And the second set of the images, I can see there is some uptake in the distal tibia on the right side, and also in the distal femora, and I can see there is uptake within the calvaria as well, bony calvarium, and some differential uptake within the soft tissues. I'm not so.
You just ignore about suspicion. So what is your conclusion?
So my conclusion for this pattern is basically super scan that is consistent with bony metastatic disease, that from in female it is breast CA, or in male patient it is likely to be prostatic CA. So I would like to, in my routine practice, correlate with the clinical history and presentation and see if patient is a known CA, then we need to correlate with any previous.
What other cause of super scan?
And the other causes of super scan are metabolic, that include hyperparathyroidism, renal failure, that include hyperparathyroidism, hyperthyroidism, and sarcoidosis. So yeah.
Sarcoidosis? You mean as What you mean, sarcoidosis as a cause of super scan?
As part of hyperparathyroidism or hypercalcemia, metabolic.
Okay. Okay, next.
Okay, so this is the lateral view of the lumbosacral spine of an skeletally mature patient. I'm just having a look through the image. The stacking abnormality I can identify is at the L1, L2 intervertebral disc space, which is showing intervertebral disc space narrowing with associated end plate irregularity involving uh, inferior end plate of L1 and superior end plate of L2 vertebra with some sclerosis. I don't see any evidence of vacuum disc phenomena, no associated prevertebral soft tissue mass, and the rest of the visualized bones are unmarkable, no evidence of anterolisthesis or spondylolysis or spondylolisthesis. So I would like to, in my routine practice, have a look on uh, other view as well. And these findings are consistent with spondylodiscitis involving L1, L2 vertebral bodies. And I need to correlate with the clinical presentation of the patient. If the patient is clinically having fever or high CRP, this will confirm my findings, and need to correlate with any previous imaging if available, and further we can suggest MRI
Why MRI?
to rule out
What?
any spinal cord involvement or phlegmon, which I don't see on this image. Okay, so the frontal chest radiograph of an adult patient, the stacking abnormality, I can see there is an opacity in the right hemithorax, which is abutting the mediastinum with an obtuse angle with the mediastinum, and I can see the hilum overlay sign. Hilum is visible through this lesion, and I can't really make out the heart outline on the right side, which is obscured by this mass. So I believe it is an anterior mediastinal mass, and the rest of the visualized bones are unmarkable. I don't see any widening of the inter rib distance or any rib lesions or any. So this is likely representing an anterior mediastinal mass, and the differential include thymoma, lymphoma, and germ cell tumors, and less likely to be a thyroid. So I would like to take it further with a CT chest with contrast.
This is a homeless patient found on the street unconscious.
So I'm requesting for the remote control.
It is yes, I accept it, but I think it is non-scrollable.
These are
So
non-scrollable
in
images.
between two images.
Okay. So I will just have a look on these images.
Yeah.
So the patient is homeless and he is presented unconscious. The stacking abnormality on these images, these are the non-contrast CT brain images, which are showing evidence of pseudo subarachnoid appearances, that is shown as loss of normal gray white matter differentiation of the brain parenchyma, with which is consistent with cerebral edema, and there is prominence of the subarachnoid spaces around the cerebral cisterns, which is consistent with pseudo subarachnoid appearances, and there is
So what is the cause of pseudo-subarachnoid? What is the mechanism?
So pseudo subarachnoid appearances include, as I mentioned, is consistent with severe cerebral injury that may include uh, hypoxic hypoxic ischemia to the brain, such as drowning, such as the patient asphyxiating injury to the patient as well, or it is basically a case of cerebral edema or acute cerebral hypoxic injury to the brain parenchyma. So 60-year-old male, 1 week history of decreased cognitive and memory function, including difficulty forming new memories, acalculia, and finger agnosia. Okay, I'm just going to scroll through these images. So these are the CT scan brain axial non-contrast images of a patient who has presented with significant memory problems. In my first view, I don't see any obvious abnormality, so I will try to have a look again. So the ventricles are normal. I don't see any ventricular dilatation. I don't see any hyperdense
Okay, so
cerebellar.
how would you proceed further? How would you proceed further?
So in my initial I mean, I don't see any evidence of intracranial bleed.
Yes.
There is no midline shift, dome ventriculomegaly, and so if the patient is having a presentation which is acute, so I need to rule out any acute pathology or infarct, which are sometimes not identified on initial CT. So I would like to have proceed with a MRI if possible.
Yeah.
Okay, so these are the MRI images. This is the flare sequence,
Yes.
which I can see there is evidence of bilateral flare hyperintense signal, predominantly involving in both medial temporal lobes, more marked on the right side. And I would like to have a look on other sequences. Is that all right?
Yes, okay.
Okay, so I will have a look on T2. T2 is also showing a T2 hyperintensity within the temporal lobes and also in the region of cerebral systems. And I don't see any other evidence of any brain parenchymal mass or any SOL, no midline shift, and no ventriculomegaly. I will go through the post-contrast images. The post-contrast images are showing not significant enhancement of these abnormalities.
Non-contributed diffusion, not good.
The diffusion weighted images are not showing any
Not
restricted
contributory,
diffusion,
yes.
is it?
Okay, yes.
Or
No
minimal
restriction.
restricted
No
diffusion?
restriction.
No restriction. So, okay. So these are basically T2 flare hyperintensities in the bilateral temporal lobes. My differential for these appearances may include herpes simplex encephalitis as a top differential, and if the patient is acutely unwell but she is not septic, she is not having fever, but she is having other cognitive decline.
Yeah.
So the other differential may include limbic encephalitis as a possibility. that is has the same presentation with T2 and flare hyperintensities involving the temporal lobes, and it is a sequelae of underlying breast or lung CA. So I would like to correlate with evidence if the patient is having these and take it further accordingly.
Next case, acute severe chest pain in another.
So acute severe chest pain, the frontal radiograph of the chest is showing mediastinal widening, and I can see there is some possible displacement of the intramural calcification in the aortic arch. So I'm suspicious about aortic dissection or aortic intramural hematoma or transaction. So I would urgently communicate these findings to the referring physician, and further imaging like CT thorax with contrast
What other cause of acute severe chest pain? You are right in this. What other cause of acute severe chest pain?
Sorry, Dr. Awadh, I can hardly hear you.
What other cause of acute severe chest pain?
So acute chest pain, it could be due to aortic dissection, it could be due to PE, central PE, or these need to be ruled out.
Okay. You still have the control.
Okay, so I'm just going through the images. These are non-contrast images of the CT thorax.
Just start by this, yes.
So this is showing evidence of intramural hematoma. I can see there is mural thickening involving the aortic arch with the displacement of the intimal calcification inward, and it is showing extension into the descending thoracic aorta and also involving the abdominal aorta as well. There is bilateral pleural fusions. I would like to have a call.
Yes, you can't cheat.
Confirm on the arterial phase images.
Yeah.
So the arterial phase images are showing these, confirm my finding of intramural type A intramural hematoma, which is a cardiothoracic surgical emergency, and it needs to be urgently communicated to the cardiothoracic surgical team for further management.
Yes.
And there is no evidence of aortic dissection on these images.
Okay, perfect. Well done, Dr. Asad. All of you are very good. Just leave the control. Yes, this is an intramural hematoma, and I asked about differential of acute chest pain. Yes, you want to exclude aortic dissection, BE, or massive or tension pneumothorax from the X-ray,
Right.
or MI.
MI,
And
yeah.
also, yes, when you provided sometimes if it is the case might be CTB pulmonary angio, CTBA, so don't you must take also a look at the aorta. Sometimes it is perfectly done and well-timed CTBA, so the aorta is nulling, but it shows intramural hematoma. So take care of such cases. You must look at all. Don't only be minded with the BE, even if they told the clinician also suspecting BE. You must be thinking again in the aortic pathology.
Yeah.
Okay. Well done. Yes, as you mentioned, exactly. Yes, and this is an autoimmune encephalitis or limbic encephalitis.
Sorry, can you increase your volume a bit, Dr.
This
Awadh?
is exactly, yes, this as you mentioned.
The CT brain was normal, was it?
Normal, or from the history there is subtle hypothesis. It is normal here. It is
normal,
exactly.
There was some.
I want to see your approach.
It is. I thought it is due to artifact. Yeah.
No, but your approach is good. No sign of. You mentioned the approach. I put it even it is normal, but you give your approach for brain CT reading is very good. So you exclude any hemorrhage, hyperdensity, That is
Okay.
that's why I put it. And yes, it is a limbic encephalitis or autoimmune encephalitis.
Okay.
Differential is herpes, but the herpes is acute presentation, as you mentioned, and even here the CSF was negative.
Right.
And this exactly, as you mentioned, pseudosubarachnoid hemorrhage, and this is the basal cistern, effaced and diffuse brain edema. Yes.
Yeah.
Nothing to add. This just to see how to approach mediastinal mass, the hilum overlay sign, and silhouetting the right cardiac border. Yes. And
It was anterior, yeah?
Yes.
Okay.
I put it only to say it is an anterior mediastinal. That is very good. Yes, and this is a spondylodiscitis, as you mentioned. And what's the next step is an MRI for cord compression and for any collection. Exactly.
Yeah.
What
Okay.
else you get?
Thank you. Thank you, Dr. Awadh.
I think you get one case.
So before we go further, we have Dr. Vasif with us. Dr. Vasif, would you like to add anything?
Sorry, one case also the metastatic super scan, also other cause metabolic, as you mentioned. Nothing to add. Yes.
Okay. Okay.
Yes, Dr. Wasi.
No, it's fine actually. I'm just here as a backup to Dr. Awadh. If he wants to consult on anything, I'll go for it.
Okay.
But otherwise, doing perfect. Nice, Marshal.
Okay. Thank you. Thank you.
Next candidate. Who's next?
Sorry, who? Ruby, are you going next?
Yeah, fine.
Okay, I will keep the time.
Okay, thank you.
Okay.
So young age female with right breast lump. Okay, I'm provided with the ultrasound images of the right breast, and I could appreciate there is a well-defined heterogeneously echogenic lesion is seen superficially in the right breast. And yeah, it's well-defined, ovoid. And I would like to assess any vascularity within. And am I supposed to scroll?
You can scroll, ask me control.
Yeah. Yes. Yeah. Okay, so it appears to be a well-defined, benign-looking lesion. And I would like to assess the previous images if available. Otherwise, the patient needs mammogram for further evaluation.
Okay, what's your thought here?
It could be a fibroadenoma, or it could be a hematoma, or if there's any significant history related, could be a lipoma.
Okay, if this young needs an mammo, I have only ultrasound.
Yeah, I forgot to, I don't remember the age of the patient.
Okay, if this is, as you mentioned, for example, hematoma, what would you like to do further? Do you need to biopsy it?
Depending on the size, if the lesion is more than 3.5 centimeter, then yes, we would biopsy it.
Why?
And if it's to rule out any malignancy. Though there are no malignant features on this, so an additional MRI would help. And depending on the patient's symptoms as well. So patient needs the triple assessment. But I forgot that I don't remember the age of the patient.
Young baby.
I mean, she's about 25 or?
Young.
They haven't mentioned. Okay,
yes.
fine.
25.
But it looks very benign and superficial
yes.
type of a lesion. I'm more concerned about could be a lipoma.
Yes,
so maybe
right.
it doesn't need further evaluation. Okay, 30-year-old male, the patient presented with history of dyspnea for approximately 4 months. No other symptoms were described. Okay, I'm provided with the chest X-ray frontal projection and an adult patient presented with the dyspnea. And I could appreciate there is bilateral asymmetrical hilar enlargement. And looking at the lung fields, I'm not able to appreciate any evidence of a mass collapse or consolidation. No evidence of any pneumothorax or pneumomediastinum, no obvious pleural effusion on either side. The cardiomediastinal contour is unremarkable. So considering the bilateral hilar lymphadenopathy, which is asymmetrical, my differentials could be a tuberculosis, it could be sarcoidosis, it could be lymphoma, or it could be a metastasis. So I would like to assess this further with detailed history of the patient, and for further evaluation, patient might need contrast enhanced CT scan of the chest, abdomen, and pelvis. And ACE levels can be done to rule out the sarcoidosis and correlation with the previous imaging, and referral to the chest physician.
Okay, how to reach the diagnosis of sarcoidosis? What else other than ACs?
Other than AC levels, patient might need the bronchoscopy and biopsy from the lymph nodes. If it shows the non-caseating granulomas, that will be in favor of sarcoidosis.
Okay, next case.
So this is the X-ray abdomen frontal projection, and I could appreciate there are bilateral medullary nephrocalcinosis is seen in both the kidneys, more on the left side, and no evidence of any calcification in the line of the ureters or urinary bladder. And rest of the visualized bowel gas pattern is unremarkable. So the differentials for the medullary nephrocalcinosis would be medullary sponge kidney and hyperparathyroidism, renal osteodystrophy, and or renal tubular acidosis, or any causes of hypercalcemia. And so patient needs detailed history and further imaging to rule out.
Patient has acute right loin pain.
Okay. There is a focus of calcification in the region of the pelvis on the right side that could be in line with the ureter or maybe in the urinary bladder. So the patient needs ultrasound evaluation to rule out any.
The ureter or urinary bladder?
Ureter more likely because of the linear tubular shape.
Do you know a name for this? Yes.
Yeah, okay. Strain Strauss.
Okay.
Strain Strauss, yeah.
This child during a basketball activity he injured.
Okay.
His ankle.
Okay. I'm provided with the X-ray right ankle in a child having basketball injury. So I'm looking for any evidence of a trauma, and I could appreciate there is an irregularity of the growth plate in the distal end of the tibia, which shows sclerotic margins and irregular outline. And there is subtle overlying soft tissue swelling along the medial aspect and no obvious trauma. So I would like to assess the other views. The lateral views would be more helpful. Okay. And on the lateral view, there is, I could appreciate there is fracture in the base of the fifth metatarsal. And
yes, this, what else? Just ignore this. Yes.
Yeah. Okay.
Keep on the ankle.
Yeah. So I'm not able to appreciate any fracture in the distal end of the tibia or the fibula here. Just the subtle irregularity of the growth plate and sclerosis. The child needs the MRI.
Why MRI?
or CT scan, further at least some advanced imaging to see the growth plate or any Salter Harris injury.
Yes.
Okay. So CT scan shows, again, it confirms the irregularity and sclerosis around the growth plate. And there is a fracture in the distal epiphysis as well.
Mhm.
Yeah, is it
Can you
scrollable?
find-
Yeah,
Yes.
okay. Okay, so there is a vertical fracture along the distal epiphysis. And so I'm looking for any other component. I'm looking for the metaphyseal injury, which I'm unable to appreciate. So this is the fracture along the vertical fracture along the epiphysis and the horizontal fracture along the growth plate. So it is the, yeah, it's the triplane fracture.
Okay.
And that is
Oh,
Salter Harris type 3.
Exactly. Yes.
75 years old female, sudden onset of severe left flank pain. Okay, I'm provided with the contrast enhanced CT scan of the abdomen in a 75-year-old patient presenting with the severe abdominal pain. I'm scrolling from cranial to the caudal, and there is evidence of pleural effusion on the left side. There is ascites, generalized ascites, and there is a large heterogeneous collection is noted in the left side of the abdomen, in the retroperitoneum. It appears to be of high attenuation, representing the hemorrhage. It is displacing the left kidney anteriorly, and the collection is seen extending through the retroperitoneum and along the paracolic gutters into the left side of the pelvis. And I'm going back to see the aorta.
Aorta is okay.
Okay. So this is a large retroperitoneal hematoma, and I could appreciate there is the contrast extravasation in the perinephric space as well, that I would further evaluate it on delayed images as well. And this patient needs the urgent referral to the interventional radiology team for embolization and surgical
What's the possible
evaluation.
cause? Okay. Do you have any idea the cause of retroperitoneal hematoma here?
Okay,
If not seen in the
image.
film, yes.
Okay. It could be post-traumatic. It could be rupture of any mass, renal mass, could be from angiomyolipoma, or it could be from the aneurysmal rupture, iatrogenic from the renal biopsy, or it could be related to if the patient is taking any anticoagulants, drug related. And
okay, patient go to interventional radiology as you mentioned, but this is another different case. I mean, case with the same diagnosis. This is an acute retroperitoneal hematoma, but I am asking, what is this?
aneurysm.
No, this one also. Checking another end. This one. What's this?
This is, I don't know, it's throwing a lot of artifacts. So is it a calculus, looks like, or some metallic density?
Patient referred to interventional radiologist, and because of that acute retroperitoneal hematoma. Then on the follow-up, this one seen, or like this one. Do you know what is this?
No, I couldn't get it.
So this complementary image. Can you describe?
Okay, so this is the, can we enlarge this image?
Sorry, because I put it as a slide.
Oh, that's fine. I will try.
Sorry for that.
It's okay. So this is the angiography done through the left renal artery, and I could appreciate there is a pacification of the segmental branches, and there are multiple contrast-filled outpouchings are seen, which is likely consistent with the multiple aneurysms. So patient might have some vasculitis, could be polyarteritis nodosa, or polycystic kidney diseases are also associated.
Could this also explain the retroperitoneal hematoma?
Yeah, yes.
Okay. Next
Okay.
patient.
Yeah. So I'm provided with the chest X-ray frontal projection in an adult patient, and there are sternotomy wires are seen. And I could appreciate there is the coarse reticulations are seen involving the right lung with significant volume loss in the right lung. And the left lung is grossly unremarkable. There is no evidence of any reticulations, no mass, no collapse, no consolidation, no pleural effusion on the left side. There is a shift of mediastinum towards the right side as well. And no obvious mass is seen in the right lung. Underlying ribs appears unremarkable on both sides. And so this could be a diffuse interstitial lung disease. And on the right side, as there are, the left lung is grossly unremarkable. It could be a transplanted lung, the left one, and the right one shows the marked UIP type of pattern. And the patient needs further imaging with this HRCT scan of the chest, referral to the chest physician. And I would like to take the detailed history. Why was this X-ray taken?
Time is up.
Yes, okay, on time, perfect. Yes, this, as you mentioned, exactly this unilateral transparent lung on top of UIB. Exactly, you perfectly describe it. Sometimes, not even sternotomy, you might see only surgical clips. So take care of surgical clips along the hila and the unilateral transplanted lung. Okay, perfect. This case, they might be given as a CT chest and abdomen, because and we must remember the vasculitis. It is multisystematic disease, not only our mind thinking of sarcoid, TB, and lymphoma. Keep vasculitis in your differential diagnosis, because it can cause a bilateral or renal infarction. They can be seen as bilateral hypodensity in the kidneys and the spleen. And also they ask the patient has hemoptysis with also lung manifestation. So keep in mind vasculitis in your differential. And and this one, just retroperitoneal hematoma, exactly as you mentioned, and active extravasation. But this, do you know now? This one may be clear also here.
From the clips and the endovascular coils, yeah, sorry.
Coil for
Coils,
embolization.
okay.
So
Yeah.
be in mind for simple things in intervention, just the basic things in intervention. After that patient, after retroperitoneal hemorrhage, as you recommend emergency refer to the IR suite. So they will do coil embolization. Exactly. You perfectly describe it and you refer it and manage it well, but maybe you don't expose to different IR hardware. So keep in mind also the vasculopathy and polyarteritis nodosa can be multisystem in the lung and kidneys and spleen, even in the mesentery. It comes with the variety. This is exactly as you mentioned, and you pick up this one. Yes, I pick up with you now. but they don't mention, yes, it is come the case for subtle heart injury. The classification, and you said it perfectly, type 3. That is great. What else we have? Yes, this one. You at first missed to mention this one. Yes, there is nephrocalcinosis, perfectly mention every type and the causes. And this I ask you about, what is this appearance? Steinstrass, yes. And this explain the pain for the patient.
Okay.
What else we have? Yes, this is sarcoidosis and the how to reach the diagnosis through transbronchial biopsy. Exactly. I think we done. Yes. Yes, that one. I want to ask Dr. Wasp, are you with us?
Yes, Dr. Awadh.
For benign lesion and hamartoma of the breast, what is the NH advice or the management?
So if there is fat within a lesion, so we don't need to do biopsy for any size.
Exactly.
If you can definitely identify fat, then it's either a lipoma or a hematoma, or maybe fat necrosis. So there's no recommendation for biopsy. For the other lesions, even if it's benign, if the patient is older than 25 and or the size of the lesion is more than 25 mm. So just remember 25 into 25. So in that case, we'll recommend biopsy.
Okay, exactly. If there's interval growth or symptomatic or very large size. Okay. Who's next?
Thank you.
Thank you. Well done.
Well, Dr. Iman is the next, as Dr. Rohit is not present.
Okay, Ruby, can you please keep the time?
Yeah, sure.
Okay. You can start.
Okay. Okay, so I'm presented with a frontal radiograph of the chest, and I can see that there is evidence of right pneumothorax with collapse of the right lung. The right lung is dropped down. Some evidence of ground glass opacification. Okay, there is enlargement of the cardiac silhouette. The left lung appeared unremarkable. I need to review the bones. There is evidence also of nasogastric tube that's passing in abnormal direction. It's moving to the left side and then going to downwards. So this is maybe malpositioned nasogastric tube passing through the lung to the abdomen, upper abdomen. And I need to inform the clinician about this and inquire, and also and ask him to retrieve this one. And there is I need to also check for evidence of fractures.
So what will you do?
I will urgently inform the clinician about the pneumothorax for placement of chest tube, and inform about the nasogastric tube that it is malpositioned and need to be replaced.
Okay, so what is the cause of pneumothorax here?
Cause of pneumothorax?
Yes.
Okay. I can't see any evidence of fractures, but still, if there is history of trauma, I need to review with CT for further for more assessment. But also, this malplacement of the nasogastric tube can be caused due to esophageal rupture. Perforation. Exclude obstruction 70. Yeah.
Okay.
So I'm presented with frontal radiograph of the pelvis, and I can see markedly dilated bowel loop seen in with the hostra seen within, and also I can see there is dilated large bowel seen at the periphery of the abdomen, and small bowel some are dilated and some are not dilated. So I'm suspecting that there is sigmoid volvulus, and I need to review the uppercuts of the to exclude pneumoperitoneum and perforation.
Do you know how they treat sigmoid volvulus?
Sigmoid volvulus in old patients, it's not treated surgically. It's treated, I think, by conservative enema. I don't remember. Sorry. Okay, so I'm presented with frontal radiograph of the abdomen and pelvis, and I can see there is evidence of retroperitoneal air seen on both sides, and there is stoma seen on the right side of the abdomen. So I think this patient maybe is post-operative patient. There is no evidence of dilated bowel loops. There is no evidence of liver seen, air seen within the liver. Regarding the bones, I think unremarkable. So I think this is post-operative patient with evidence of intra and retroperitoneal air, which may suggest that there is a rupture of retroperitoneal viscus. I need to further assess with CT.
Next case. Ask control, please. Can you ask control?
Yeah, I did. Okay. So this is CT post-contrast coronal images of the abdomen and pelvis, and I can see there is multiple hypo-enhancing liver lesions seen scattered within the liver, and just going the portal vein is patent, and there is dilatation, I think, within the common bile duct. I need to assess the pancreas again. I need to return to the pancreas. I can't see any obstructing lesions seen within the pancreas. Okay. I'm sorry, but it just. Okay, the spleen appears unremarkable. Both kidneys appear also unremarkable.
Okay. There is a little noise from your mic, maybe. Okay, no problem.
Okay, I'm sorry for that.
Okay.
No, I think you're speaking directly into the mic, because it's your breathing sound more than anything else. So if you just keep it just below your mouth, it should be fine.
Okay. Maybe this is fine.
Yes, it's better.
Okay. Can I go through the axial images?
Yes.
Okay, so there is soft tissue seen within soft tissue lesion seen within the peritoneum. There is no surrounding fat stranding, and there is multiple peritoneal nodules also. It's not this one. There is multiple smaller ones as well. I need to search for malignancy, obstructing mass. I can't find till now actually. Gallbladder is not seen. So there is evidence of hypoenhanced. There is evidence also of air within the intraperitoneal foci of air, which may represent also rupture of some of the bowel loops. Sorry, there is multiple. There is dilated evidence of dilated colon. The colon is markedly dilated, and on the descending colon there is some evidence of loss of rostra. I'm going down. I need to assess the sigmoid. There is the transition zone is at the sigmoid colon, and there is multiple diverticuli seen as well in the sigmoid. So maybe there is maybe
can you show it to me? Okay, what else?
These two foci of air, but then these also these.
Okay, what else?
Okay. So this may be the cause of air within the peritoneum, but there is no marked thickening actually within the sigmoid to suggest that this is diverticulitis. There is evidence of the irregular thickening of one of the bowel loops seen within the pelvis with surrounding fat stranding and lymph nodes, multiple small lymph nodes. So this is actually part of the sigmoid colon, and I think so. My diagnosis will be sigmoid colon cancer with multiple peritoneal and liver metastasis. I need to inform the clinician about these findings and refer to the GI.
What else? Can you give me the summary? The diagnosis totally?
Okay, so it's most. Yes, it's there is sigmoid colon evidence of sigmoid colon wall thickening, which most likely can be cancer with peritoneal metastasis and hepatic metastasis, and there is evidence of pneumoperitoneum may be related to rupture of one of the sigmoid diverticuli as well. Differential can be related to sigmoid diverticulitis. But actually this is a regular thickening, so I'm more and the presence of peritoneal and liver metastasis is more in favor with malignancy.
Yes.
Okay, so I'm presented with abdominal and chest radiograph of a baby, and I can see that there is multiple dilated bowel loops, and there is evidence of a pneumatosis intestinalis, and there is football sign with lucency seen on the liver and in the middle of the abdomen. So I think there is evidence of intraperitoneal perforation with air. There is no air seen projecting over the liver shadow. The upper lung fields are unremarkable. So I'm suspecting this is an necrotizing enterocolitis with bowel perforation. So I would inform the surgical team urgently for further management. I think that's all. To confirm this, may I ask for the cubitus with left side down to confirm if there is evidence of intraperitoneal air. So this is the cubitus view, and I can see there is free air seen in the upper side. This is left side up, but still I can see predict free air seen. So this confirms pneumoperitoneum.
Okay. What about the lung? You said it is clear. Are you sure?
Okay, I will review the lungs again. There is some streaky reticular shadows seen in both lungs. This is the left. So this baby is dextrocardiac. And but the liver is on the right side, so there is no situs, just dextrocardia. And lung fields, There is no small volume. I think the baby is preterm. There is, I assume he is preterm because there is no ossification center within the hemorrhage. So this preterm can represent also ARDS with these streaky shadows. So this can be a mild form of ARDS. I need to convey these findings to the clinician and ask about the condition of the baby. And for the NEC, we need to urgently manage this condition.
Perfect. But I don't hear you whether you comment on the line and you.
Oh no. Okay. So yes. Sorry. Yes. Okay. Yes. A nasogastric tube is seen placed, the inferior tube is below the diaphragm, so it's within good position, and the venous catheter is seen within the liver, just below the IVC and the atrial junction. So I think also it is in a good position.
Yes. So perfect. Well done. I think we finished. You are the last one. Sorry for little case. I'm giving only 5 cases, I think, but you do well. Okay. So let us go to the feedback. Yes, perfectly done here. But you mentioned you always when there's line and tube, start by them. You hear me, Dr. Iman?
Yes, I hear you. One.
Yes. Yes, so always start when you see line and tube, their position. And yes, there is falciform ligament sign. Otherwise, you describe well the football sign with early ocensia and the bubbly necrotizing enterocolitis. And the lungs also, you must, before say it is normal, check well, because it is continuum altogether preterm with all manifestation. So it is necrotizing enterocolitis with perforation and RDS.
So just one comment, Dr. Awadh. There's no dextrocardia, right?
No.
No dextrocardia. Another thing would be ARDS is not the same as RDS. There are 2 separate clinical syndromes. I think Dr. Iman said ARDS.
Yes, sorry. I mean RDS, hyaline membrane
yeah,
disease.
of course. Yes, of course you meant RDS. And basically, whenever you see pneumoperitoneum or RDS, so you have to, if you're seeing the chest, you have to comment on the abdomen. If you're seeing the abdomen, you have to comment on the chest. Sometimes the examiner may also ask you what can be the other associated features. Okay, so you'll have hemorrhage in the brain and the other related preterm conditions. So you should be very familiar with the whole spectrum of the disease and just be fluent in your terminology. So it should just come out automatically because it's a very common exam case.
Yes. This one. Yes. This one, yes, although it is Awadh and divertically, or diverticulosis is okay, but there is sigmoid colon carcinoma, which is perforated, and the cause of pneumoretroperitoneum here. So it is uncommon to see perforated colonic cancer, but it can be with, and they might start with the Blair radiograph with the pneumoretroperitoneum as the X-ray before. And the patient is known with the colonic carcinoma and chemotherapy, but there is later on developed pneumoretroperitoneum due to perforated sigmoid carcinoma, for example. And here you pick up the peritoneal deposit, yes, and the bilobar hepatic deposit. So there is no sign of bowel obstruction, only perforated sigmoid carcinoma. Yes, exactly. And this one, yes, post-operative, as you mentioned, you pick up the stoma and the retroperitoneal air nicely, so perfectly done. And also the cause, as I mentioned, post-ERCP, you must mention if there is any history of ERCP, but this from the stoma here and the others, yes, it is post-operative pneumoretroperitoneal, exactly. The management, yes, the differential is cecal volvulus, and we must differentiate because the treatment is different. In cecal, it is cervical, as you mentioned, and in the sigmoid, it is a rectal deflates tube or rectal tube deflation. Okay, Dr. Iman?
Yes, okay.
Otherwise, you pick up the birth rate negative, no free air, and other things, and you described it well. This one again, when you presented with a chest X-ray with line and tube, you must start your comment by line and tube.
Yes.
Then describe. You mentioned first pneumothorax, okay. Even if you mentioned the pneumothorax first, no problem, but don't forget to comment on the nasogastric tube. It is not maybe, it is malposition, and the cause of pneumothorax is here is the multiple triad and lung injury as a cause of pneumothorax. Also, there might be apical left pneumothorax here, but it is not obvious well, so I will not, you will not penalize for it. But you must also, and you mentioned perfect, that you will back up or urgently refer for this tube to be removed, and the management of the pneumothorax, as you mentioned. What else you got? I think. Do you have any other case other than this?
No, I think this is the
Yes.
last.
Okay. Sorry, it
Thank
was
you,
a
Dr. Awadh.
rapid session, short only.
Thank you.
Okay. But really, cases are typical and easy. Any more question? I will stop here.
Yes, thank you, Dr. Awadh. It was like nice collection of the cases which are basically very common for the exam purpose, and it's just about the repetition and to make us familiar how to present these cases.
Yes, it is just a repetition. Okay, you say you will see it. It is just a repetition.
Yeah, thank you so much, and yeah, thank you everybody for joining. See you